Good morning, everybody. Welcome to Pediatric Grand Rounds. I'm super excited to hear our lecture for today, so we'll get started. I have the pleasure of introducing Dr. Nick Brown, who's an assistant professor in pediatric cardiology at the University of Washington School of Medicine and attending physician in cardiology here at Seattle Children's. As a non-invasive imaging cardiologist, Dr. Brown uses a multimodality approach to enhance our understanding of congenital heart disease. Within this space, he's focused on use of newer MRI techniques, such as 4D flow, and using imaging data sets to create 3D models, which can be viewed in virtual reality for pre-surgical planning. Dr. Brown is also actively involved in teaching and uses these models for trainee and patient education. And for our education today, we're really excited to hear from you. Welcome, Dr. Brown. Thanks, everybody.
Thank you. Got a group of cardiologists in the room, so I appreciate the support. So before I start, I was going to actually hand around some models. So these are some that one of our surgeons, Lester, gives to some of our, you can take some of them around, uses to teach some of our med students. And so you may notice that they feel a little bit waxy. And it's because these have actually been fixed with a paraffin wax technique. So usually you think of people putting on gloves and pulling, specimens out of formaldehyde liquid, but these are actually more solid wax models, but they're real explanted hearts. And so I wanted to pass these around because I'm talk about, some of the newest models are actually from the 80s. So these are pretty old models, but they, the structure and integrity of the hearts is nice. There's one. I think one of the more interesting ones, one is a hypoplastic left heart, but just the scale of how small the heart is, I think is really interesting. Yeah, the small one. And then there's one with a bioprosthetic valve, and then one's a TET with a conduit. And then there's a printed model, too, of a coarc. So, all right, let's see. I can advance slides here. I don't have any disclosures. So the objective, so I want to contrast some of the pros and cons of various ways that we display our medical imaging, especially for complex congenital heart disease. Praise the value of the different technology in this area. So how do we go from 2D to 3D to more advanced modeling? Incorporate some newer MRI techniques that we're starting to use to understand the physiology, and then illustrate the benefits of some shared expertise between our group and the 3D Innovation Lab that helps with a lot of our 3D printing. So the practice gaps, and I think for this group and everybody online, I think is just understanding that this complex congenital heart disease in a lot of ways is limited by our visualization tools. And it's unapproachable for a lot of other providers and families. So how do we use some of these 3D models, virtual reality, newer techniques to bridge that gap and provide some more insights into pre-surgical planning in a way that really helps improve our patient outcomes. And then just future use of these models, I think, has a lot of potential to help with medical education and patient understanding of their disease. So historically, we have used echo for a lot of our intracardiac visualization. It does visualize some extracardiac structures, especially in young kids who have better acoustic windows. But it's best for valve structures, ventricular function, shunting lesions. And then we really tend to use our cross-sectional imaging or MRI-CT a lot more for extravascular structures. So all of the extravascular anatomy. With MRI, it takes a little bit longer time to acquire, but you get the added physiology that comes with getting an MRI. And then the CT is mainly anatomical, but is higher resolution. It's fast. You can get a quick single-phase CT with, without having to sedate a lot of neonates. So that's something we tend to go to. Usually, we mentally combine this, so we sort of show the echo, the 2D echo images, then we show the CT images, and then we kind of put this together in our minds as a mental composite model that we then use for planning. And we're always hoping that this will match up with what the surgeon finds in the OR, which is often the case, but there's occasionally surprises of things we didn't see very well. And then when we take that, we mentally make that model, and then usually what happens is we, as the cardiologist, hand draw a model of kind of what that looks like to show that to the families. So just as a demonstration of what this looks like, so we take a bunch of 2D slices through the heart, and usually we will sweep through the heart structure. So the top left picture is a picture of an echo with color superimposed on it. And you can see, I mean, this echo is an abnormal echo with the heart over to the right side. Both outflows are coming off of one chamber, but we're really trying to put this together in 3D by sweeping through the anatomy with a bunch of 2D planes, which is challenging. And then we scroll through the CT or the MRI, and then usually in conference we say, we'll sort of put that together in a mental model, and then we get this kind of hazy model of what we think the things will look like, and usually we have a pretty good idea of things, but I think putting it all together in one model is sometimes challenging. And then we then take this, draw it for the family, and depending on the artistic abilities of the cardiologist, it becomes, I think for the families especially, it's sometimes pretty challenging to understand their kids' complex congenital heart disease. And so I think we usually have this decision-making cycle where it's, there's strengths and weaknesses of each of these modalities. The resolution of the imaging can be variable. We display it in these 2D views where we're cutting through the heart in multiple views. And then I think what we sometimes get to, and this is, I think some of this is just the resolution of our imaging doesn't get to what the surgeons need, but it's, we'll have to make the final decision of what we're going to do when we see, things in the OR. And then, occasionally there are things that come up in the OR that we didn't see as well in the pre-op imaging, and so then we think, well, could we have done something differently? Could we have imaged things or displayed things differently? So there's been some newer innovations with imaging. So some of them that I've tried to harness towards displaying things in a way that is a little bit more intuitive. So we have 3D echo, 4D flow by MRI, and then virtual reality or extended reality. It's kind of the broader term for it. That are some newer technologies that people are starting to use to help with planning. So I think my ultimate goal is to say, how do I take the anatomic detail you get from CT, the valve structures we maybe get from 3D echo, and some of the physiology we get from an MRI, how do we put some of that together in a more cohesive way that we can actually make a composite in vivo model of the patient-specific anatomy? So I'll start with anatomic modeling. So again, this is how our gold standard for just our initial testing is a 2D echo. And so it's easily accessible. We can take this to any patient's bedside. It's standard of care. We usually get pretty good resolution, temporal and spatial resolution in most pediatric patients. And in this kid, again, this is that same complex heart we were showing, but with some of our training, we can put together how things look like in 3D based off of sweeping through the anatomy with 2D. So this kid has a dextrocardic heart, so the heart is pointed over to the right. There's a AV septal defect. Both the outflows come off of this left-sided ventricle, and then one of the outflows is stenotic. And so there's lots of things going on in this picture, but we kind of put this together. But I think it's challenging to figure out how to show this to the surgeons, how to show this to the families in a way that is intuitive. So I think this is from a 3D echo chapter, but I think this is helpful that in going from 2D to 3D, we really had to go from taking this cross-sectional approach of cutting through the heart in multiple 2D planes and bridging the gap to what the surgeon ends up seeing in the OR. 3D imaging really gives us more opportunities for that type of visualization where you can actually crop through things, expose them, have endoluminal views that a surgeon would be more used to seeing in the OR. So this is another picture from ROR, but this is a patient with a Fontan conduit that they're putting in. So one of the ways that we can do that that's echo based is we can go from 2D to 3D echo. So this takes, rather than a 2D echo having a line of crystals that acquires a 2D slice, it actually it has a matrix of crystals, and it sends out a pyramid of ultrasound beams, and then we get this whole 3D data set that then you can manipulate, you can do endoluminal views, you can adjust it, do cut planes through it, but there's lots of opportunities to interact with that data set and recreate any 2D views or get the endoluminal 3D views. It can be a little bit limited by, it's a little bit operator, patient dependent if they're not very cooperative and it's trying to acquire the image over multiple heartbeats. It can be a little bit challenging, but in this patient, this is a patient with an AV septal defect who has a common, you can see this is a hole in the middle of the heart, the crux of the heart. And then there's a common AV valve. And so from some of these views, we get multiple angles of things, and we can analyze it in lots of different ways that we can't really do as easily with 2D imaging. So this is an example of a 2D image of an aortic valve in the OR. And so you can see there's a coaptation defect in the valve here between the 3 leaflets. But it's a little bit challenging to see, what is exactly the mechanism of why is it not functioning well. With 3D imaging, you can actually get a little bit more of the body of the leaflets. You can see the leaflets are curled, rolled. Some of these leaflets on this side are fused together. And then with 3D imaging, you actually get more of a better picture of the regurgitation and where it's regurgitating through the valve in more of a 3D view of things. So it's more accurate for us in assessing the mechanism of regurgitation. And I think this is a pretty good example too. So this is a patient with a complex canal, so an AV valve. So there's an AV septal defect with a primum ASD, an inlet VSD. There's multiple shunting lesions, so the blue flow is shunting going across these holes. But then there's also regurgitation that's going up this direction towards the right atrium. So there's lots of things going on in this picture that are a little bit hard to sort through with 2D imaging. But with 3D imaging, this is actually from the ventricles looking up at the valve, and here's the aorta. So this is the left side of the valve, this is the right side of the valve, and you can actually get a better feel for the middle of the valve is a little bit separated. And looking at it from above, so from more of a surgeon view or atrial view, so this is the right side of the valve, the left side of the valve, and the aorta, you can actually see that the bridging leaflets are actually adhered to the septum, but in a way that they're separated from each other. And so that is leading to regurgitation through the middle of the valve, in addition to the shunting across the holes, but it gives us a better picture of the mechanism of regurgitation for complex hearts. There are actually some newer tools for us to take some of these 3D echoes and segment them or model them in the way that you can actually create like a splitting plane and say, I want to divide the valve here, and you can get an idea of how much area is left on either side of the valve. You can get multiple valve measurements, but you can do a little bit more analysis, like quantitative analysis of the valve, rather than it just kind of being a purely qualitative 3D echo. So that's 3D echo. So that's kind of our initial study that we tend to do for all of our patients. But then what about for cross-sectional imaging, or if we don't see something well, like pulmonary veins, pulmonary arteries, some vascular anomalies that are associated with our patients that have congenital heart disease? Well, we tend to use CT or MRI for those. CT has the best spatial resolution. It's a little bit limited temporal resolution compared to MRI, but it's great for getting a really good detailed image of a lot of intracardiac structures, including some valvar structures. But it can be performed pretty quickly, especially if you just want like a quick static view of the anatomy. And then one of the things that I'm doing in this picture is you can rotate things around. We call it multiplanar reformatting, but you can recreate any 2D views that you want from the MRI, as well as get a 3D view of what the heart looks like. So the quickest way that we can show this in our conferences is something called volume rendering. So it creates the illusion of 3D on a 2D screen. So it uses lighting and shading techniques to give us to make something on a 2D screen look more 3D. So this is pretty fast. There's not a lot of like segmentation or post-processing required. One of the problems, though, is it's difficult for us to really get true endoluminal views. You can see in the beginning of the clip, you can window level this to kind of try and get a better view of things. But this is, one of our quickest things that we can do in conference. One of my favorite new things is actually called cinematic rendering, which is really fun. But it actually uses multiple different lighting techniques, and so it has more complex shading and gives you an even more realistic three-dimensional view of things. Still a little bit challenging for endoluminal views, but it's really gives you these really cinematic, high-quality renderings of things. So the way we make our models based on the CT or MRI, so we actually, it's called surface rendering. So we actually, you threshold defined what voxels or what pixels you want to keep. And then we say, well, I want to keep the blood pool. Then you can hollow it out and create a shell. And it creates a really smooth surface. So that makes it a lot easier for us to look inside the heart. So this is, us, just the initial steps of us making a 3D heart model. From there, I think historically people have moved from, okay, let's examine these explained hearts that is passing around, to going to, okay, how do we 3D print them? And that historically people you make that virtual model and then you 3D print it. And people, have used it for all kinds of things. I think some of the challenges is it takes time, it's expensive to print it, it's difficult to cut it through from multiple angles. So you can see from these hearts that we passed around that they've pre-cut it, and fixated it in a specific view, but you can't cut it, put it back, cut it from a different angle, put it back in a very intuitive way. It's also hard for thin structures, so it's just the limits of how small can you print, and it makes group education difficult. So I don't know. I think for everybody that's huddled around like somebody who's trying to show a gross specimen, it can be challenging for trainees to be able to see it. It is probably best for surgical practice, though, for simulation of somebody practicing sewing in a patch. That kind of tactile training, I think, is something that the printing is really useful for. But in terms of just understanding the anatomy, I think there's a lot of places that have moved away from printing and have said, well, we have this virtual model. Now there's other ways that we can actually interact with it rather than being forced to print it. And so we take that 3D model and you can actually do a lot more things with color coding. And so printing out things with color coding can be a little bit challenging. But with this, there's limitless ways that you can cut into the heart, put it back, color code things. So in this case, we actually color coded systemic veins a darker blue color. The pulmonary veins are in that lighter blue color. This patient has an AV septal defect in brown, and then the AV valve annulus is in this purple color. And then these outflows are predominantly coming off of this left-sided ventricle. And this is nice for group education because I can display this on the screen for all of you to see, and less of the huddling around something that's a little bit difficult to see. This is that same heart, so I can take away the heart structures and just look at some of the landmarks in the vessels. And so, again, these are all the left-sided pulmonary veins in light blue, right-sided pulmonary veins on the other side, and then systemic veins coming to each atrium. But this creates a lot of challenges with how do you baffle some of these veins to the correct side if you're going to try and do a two-ventricle repair. And so in a patient like this who has all kinds of systemic venous and pulmonary venous anomalies, and also an AV septal defect, this gives us more opportunities to visualize things and plan things out. And this has actually been used in medical education. I think that what I was going to highlight that another group showed is that, especially for more complex heart disease, that this virtual reality really makes a big difference, or even this types of additional visualization tools. So you go from an ASD to a coarc to a patient with a tetralogy of Fallot who has multiple aortopulmonary collaterals where it gets incredibly complicated. They actually scored how they did and tested their knowledge before and after reviewing these cases and found, especially for the most complex hearts, that these better visualization tools seem to be really helpful especially for trainees. So I think what has been challenging is working with the surgeons and with our 3D lab. I often come to them and say, how can I make this part thinner? How can we show this? We didn't show this well. And then the 3D lab will often come back to me and say, I don't know what I'm looking at. What structure is this? How do I, can you give me some guidance on how we can segment this so that we save each other time? Because I think this segmentation often takes a lot of time. And then the surgeons, I'll show it to the surgeons and say, well, that's actually not how I would see it in the OR. I would actually tend to view things from this angle. So there's been a lot of back and forth with the 3D lab of how can we better collaborate. So one of the ways we've done it is they've done some initial segmentations and then all landmark things. Okay, this is the left-sided SVC, this is the right-sided SVC. These are actually pulmonary veins, and this is actually a pulmonary artery. And then they'll make an initial model, and then I say, well, we actually didn't include the PDA, or we needed to include more of the coronaries or something like that. So there's notes we're able to write back and forth to each other. And then I think, once we have more of a model, there's actually ways too where we can take this model and then disseminate it in a way that's more intuitive to other people. So I can take this, and we now have software tools where we can share this with a surgeon, we can share this with a primary cardiologist, who can then share it with the family. And this was actually a patient who had multiple, who had major aortopulmonary collaterals, so all of these large collateral vessels coming off the aorta that they then had to cut at the base of those arteries, and they had to reconnect them all to a conduit. So kind of recreate pulmonary arteries in a patient who doesn't have them. But this is nice because they actually had this on the screen in the OR, and so the surgeon could reference this live during the case, and mainly for landmarks. So where is this collateral in relationship to the left bronchus, in relationship to the left pulmonary veins? And there's ways that you can turn structures on and off. You can cut to them from multiple angles, make them transparent. So there's ways that it's interactive even in an intra-op environment. So I think one of the biggest challenges is you take this image and you zoom it up, and even this 3D image on a 2D screen, you just totally lose depth perception when you zoom in and try and make this heart big and step into the heart and walk through it. So if you want to go on a Magic School Bus ride, this is not quite the way to do it. So I had to include a ChatGPT reference just because I felt like that's obligatory at this point. So I asked to create an image of somebody exploring congenital heart disease in VR, and this is what it gave me. I asked them to make them a little bit more excited, and it gave me this. And then I said, well, this is not really congenital heart disease, so can you swap out the heart and give me one that actually has congenital heart disease? And it just punched a hole through the front of the heart. So I think maybe some limits in the models that ChatGPT has access to for congenital heart disease, but this is the best I could do. So it tried hard. So in entering virtual reality, so how do we take this and say, well, how do we get to a point where we can step through the heart in a way that's more intuitive? There's a spectrum of congenital heart disease, so there is, or for extended reality, so you can go from everything. People have done holographic projections in the OR where the surgeon has something literally in their hand, but can see everything around them in the OR. Everything to totally immersive, people putting on VR headsets where you can't see anything else that's going around, but you're totally immersed in a VR space. So there's a whole spectrum of how immersed you end up getting in it. So here's an example of us walking through things. So this is that volume rendering, so kind of the quick rendering you can do, but this is in virtual reality. And even this, when I'm showing this on a 2D screen, it's not quite the same as if I was able to have each of you put on a headset. But this is just a quick view. Doesn't take hardly any time at all to just you window level this to show the structures you want, and then you can load it into VR. But this is actually so this is more of a surface rendering. So this is a patient who had an LPA sling. So this is looking from the back, looking posteriorly at the airway and the left PA. And so this is the LPA coming up and over around the trachea out to the left lung. This patient also had abnormal airway anomalies. So this patient had complete tracheal rings, and also had a bridging bronchus. So it has some abnormal lobar branching, but you can actually pull the structures out from each other. You can cut into them. You can put them back. You can make them transparent. You can pretty much do, lots of different things, whatever you want to do with them in terms of visualization. But this was helpful. We had ENT and the cardiac surgeons come to my office and explore and walk through it, and then they actually did the case, and the case was successful. But I think it was helpful for them because this is one more dimension from the 3D we're showing on the 2D screen. So this is actually this is a patient with more complex congenital heart disease. So this patient, we're actually cutting through them. The yellow is a VSD, and so this patient had a complex anatomy where the yellow is a VSD, but both outflows are actually coming off of one of the ventricles. So they have double outlet right ventricle. And so in this case, they're trying to figure out how do we close the VSD in a way that we baffle out to one of those outflows. And there's options of baffling to the pulmonary artery in blue or all the way out to the aorta in red, but knowing what structures are going to be in the way of that baffle is really where this is the most helpful for complex surgical planning. And I think one of the things that was helpful for the surgeons when they first put on the headsets, walked through things, cut into things, they said, oh, this actually feels like I'm putting on the loops that I wear in the OR, because this is the endoluminal views that they are used to. And I think there's probably some steps in getting it from looking more cartoon-based to looking more realistic, but I think just even that step of bridging that gap, I think, was helpful for them. So then I think the other thing that, looking at it on a 2D screen, you can actually, when you're in virtual reality, I could blow the heart up as big as this room and then really go on that magic school bus type of ride of stepping into the heart. And then when the heart is as big as the room, then you can make measurements, you can cut into things, see what's on the other side of structures. There's really a lot of interactive tools now that you can use. And so for our surgical planning, so this is one of our surgeons walking through things in virtual reality. And then these are all based on DICOM imaging data sets, so it retains all the dimensions that we get from the CT or MRI. So we can actually make measurements of what the distance is going to be, so a baffle distance of creating a patch from the VSD all the way out to that aorta. We can make some pre-op measurements of how far away things are. And then I think one of the coolest things that has become available on some newer software we're using is we can actually take some of these hearts and do baffle planning. And so these baffles or these VSD, these patches we're putting in are not just straight patches. They actually they have to have some complex shape that you include the right structures you want to include and exclude the ones you don't want to include. So in this patient has dextrocardia, all the pulmonary veins are in pink, and all the systemic veins are in this green color. But we have to figure out a way that we baffle these pulmonary veins through this ASD, which is in the LA is in the morphologic LA is in brown on the other side. We have to figure out how do you baffle those across while excluding this left SVC in the coronary sinus. But you can actually step through this, you can create a baffle shape, you can plan all this out before the patient even goes to the OR. And then, so we're drawing in the baffle, avoiding this coronary sinus where there's right SVC flow coming into the systemic venous atrium. And then, even after you make this baffle, you can deform it, give it some redundancy. So there's, some additional tools you can do with that. So, and this was another case we used this clinically on a patient, and it was, helpful for the surgeons to even just visualizing things. There's places that have even tried to flatten this out and laser project it on the back table for cutting the VS, patches. But I think this is, first steps in exploring things. And so then we have CT, we have 3D echo, but I think they are both good at different things. So I was inspired by looking through some of the literature to see what ways could I fuse these together and maybe make some ways that we get some of the best of both worlds. There are some people who have tried to fuse things together, print them out. So this is actually a poster somebody presented where they modeled out the valves based off of 3D echo and then the rest of the anatomy by CT and then fused them together. So the holographic looking image is actually the 3D echo, which is displayed on top of the CT. So we're aligning the annulus and actually trying to fuse these modalities together. And then, so this is actually in VR. So we took that model that we had made, and you can actually take the 3D echo, superimpose it on that CT model I just showed, and you actually get, so this is a tricuspid valve that has 3 leaflets, and you can see how it's opening, where it is in relationship to some of the other heart structures. So I think the benefits for us so far in this kind of initial feasibility stage is I think it's helped us confirm how the surgeons are going to approach things. So are they going to go through the right atrium, through the aorta, through the PA, through the front of the RV, like ChatGPT suggested, and then some increased confidence in the surgical approach. So they still make their final decision based on what they see in the OR, but less of the, we'll kind of see what we end up seeing in the OR to, okay, we actually have some more confidence of how things are related to each other leading into things. And then allowing for some of those pre-surgical measurements of how far away is this, rather than opening up the heart and then they're taking, their measurements in the OR. They get to do some of that ahead of time. And then I think there's still just challenges in us understanding valve structures in the region of these patches that they're trying to put in. Okay, so we talked about anatomy. So it's a lot of anatomical stuff, but we've really not talked about any flow stuff, any physiology. So how does that all fit into these anatomic models? So one of the things people have tried to do is CFD modeling, so computational flow modeling. So you take that data set, even if it's a static data set, and you can set boundary conditions, and you use conservation of energy principles to simulate blood flow patterns, and you can speed up the blood flow through it. You can change properties of the dimensions of things, and you can actually run a bunch of simulations, and that's kind of how people have done surgical simulations with what is the best way to baffle things, what is the best way to put in a Fontan conduit in a way that you get the best flow to both lungs. So, but you can really analyze a lot of higher order flow properties that everything like the UW engineering team is looking into, like wall shear stress, energy loss, pressure field, so lots of things that are more than just how much flow is going to this lung or how much is going to the other lung. But I think, going from that, I think what has been interesting as like a development in the MRI field is that there are ways we can actually do this in a more patient-specific way without having to assume a bunch of boundary conditions. And so historically, the way we measure flow through vessels by MRI, which for any complex patient we see, we align the data set to get to put a plane through the blood vessel, so through a cross-section of the blood vessel. And then we actually look at the blood flow going through that one 2D plane, and we go one blood vessel at a time, which takes 2 to 3 minutes usually. And so we get some idea of how are things going. It's one blood vessel at a time, but there are some newer techniques where we can actually take this and say, how do we actually get, this is always like the one that people present at conferences, but these data sets, this is called 4D flow. It'll actually take a 3D slab of the heart and look at all of the blood flow patterns in 3 cardinal dimensions, and then put it together as vectors that then you can look at how things are moving over time. So the 4th dimension is a nod to Einstein, of time is the 4th dimension. So this 3D flow through the heart, over time, we get 4D flow. This takes 10 minutes, so you, rather than 2 to 3 minutes for each blood vessel, in a complex Fontan patient might take 30, 45 minutes, can take as short as 10 minutes. And this is actually a patient-specific in vivo flow model, and then we can analyze anything we want to after the patient's off the table. So you can place all the 2D planes, measure all the standard clinical flows we need to measure, but then there's also tons of research potential for this, for us to analyze all of those CFD type of things that people are looking into for flow modeling. So this is actually, so you can actually look at streamlines, so how are things flowing through the heart, confirmed shunts, and then this is a patient who has bicuspid aortic valve, so this is regurgitation from the aortic valve, and they also have a coarct, so there's a narrowing here with some turbulence, and then this patient also had swirling in the main dilated main pulmonary artery. And so, when we are measuring things by 2D flows, we're assuming that there's laminar blood flow and not turbulent swirling blood flow. So this is really nice. We can, measure whatever we want to after the fact. The time savings of this, and we talked about it a second ago, but these are all the flows we would measure for a Fontan. So this is 8 to 10 flows we would measure for a patient who has a baffle or conduit connecting the IVC to the PAs and the SVC directly connected into the PAs. And we're trying to measure all the blood flow patterns through all the arteries, veins, going in and out of the heart to figure out how much blood flow is going to the lungs versus the body, how much is going to each lung, what's the collateral burden. And the standard for this is that it takes 20 to 30 minutes, but in this 4D flow data set, we get that in 10 minutes, and we get all of this extra information too. So this is a clinical case. So that same type of case where it's a complex patient who has all of these flows that we have to measure, and we can use this 3D model to analyze whatever we want to. And this is superimposed flows of all 10 of the vessels we were trying to measure. And this is also helpful for just confirming streaming. So we have patients that have who have AVMs to the lungs because they don't get some hepatic factor that is equally distributed to both lungs. But we can actually see in these types of patients, there's a lot of this IVC streaming that tends to go to the LPA, a lot of the Glenn streaming that tends to go to the RPA. We can confirm a lot of streaming flow patterns and contribution of flow to each lung. So it's super helpful in these types of patients. And then, so some of those higher order flow properties that they analyze with computational flow models, we can get that in a patient-specific model with this 4D flow. And so this is energy loss in a Fontan conduit. And so this is something that, beyond just the clinical utility of shortening studies and getting that extra information, there's lots of research potential here. And we've actually been able to do this. So this has been done without contrast. So people have done this types of studies without having to place an IV, without giving contrast. And this is some research we've done here. And so this is correlation of our non-contrast 4D flow with our standard 2D flows. And even for smaller low velocity vessels like the SVC, it correlates pretty well. We do some Bland-Altman agreement plots, so how well do the two agree with each other, and there's not significant bias between the two. Like we tend to underestimate a little bit by 4D flow, but tends to be less than 10%. And it actually tends to agree with our stroke volumes or some of the other MRI things we're measuring even better than some of our 2D flows, even in some of these cases where we didn't have to use contrast. There's some places who have gotten really creative with this, who have actually put patients in MR-compatible incubators and put them in there, no sedation, no contrast, and have been able to get these types of 4D flow images and extended that even to the fetal realm. So people doing fetal cardiac 4D flow using some accelerated 4D flow techniques, but really cool stuff. And then I think, so how do we get to, we talked about anatomy, we've talked about flow stuff, flow properties we get from MRI, but how do we sort of put all of this together? There are some newer MRI techniques that use a blood pool contrast agent to enhance the signal, get closer to the CT resolution that you get, but actually get the anatomy function that you might get from echo and CT from an MRI. And then you can even take this, create multiple slices through the heart, and get all of your functional numbers, when we contour diastole, systole, and we can calculate things like an ejection fraction, volumes, and kind of do all of that in one data set. And some people have even given that blood pool contrast agent, scanned these patients, done a more compact, abbreviated MRI protocol, shortened scan times for some of these neonates to 30 minutes rather than the 90 minutes or two time slots we typically have to do for our MRIs. So really speeding things up, getting more information, and then improving the quality of our imaging. So I think just in terms of future work, hoping to continue to work on fusing kind of the best of all of these modalities and put them together in a way that, in VR, the other thing about, compared to a printed model is you can look at a dynamic data set. And so you can look at something, so having a fully dynamic data set that has all of the structures that we're interested in, and then include some of the flow stuff we get from the 4D flow MRI things. And there's still lots of utility for computational flow modeling. So the UW engineering team is doing all kinds of computational flow modeling and running simulations. And so all of the advances in GPUs and graphics cards and then all of the ways that AI has helped with segmentation, they're using a lot of those tools to speed things up and run a bunch of simulations. So you could take one of these hearts, say this is what the anatomy looks like, here's what the 4D flow currently looks like, and then make modifications and then run simulations like that. People have used 4D flow to inform a lot of computational flow modeling. So So I wanted to acknowledge the 3D Innovation Lab, the printing team that's helped with segmenting these hearts, and then the echo, cross-sectional imaging teams I work with, and then Christina and Lubomir are some of our cardiac surgeons who have been heavily invested and have really helped push things forward and given feedback about what things they end up finding in the OR and helped us refine the model. So here's some references for the talk, and then I'll leave this up, and it really does help if you guys are able to give me some feedback.
How much, if at all, are you using this with like families for planning and making sure they understand what the surgery is going to be that their child is signed up for?
This one that I showed earlier, like this was a VR video that I was able to share with the primary cardiologist, who then could share it with the family. And so I think, there's a recent New York Times article from Boston and some of the using some of this technology, but sharing this with families really is a huge impact, because some of our families have kids that have very complex congenital heart disease, have never really understood how everything is connected, and have things drawn in stick figure form for them. But I think, so we've been able to share this with families, and even in ways that like sharing these types of models here, where like families can actually, like the primary cardiologist can turn things on and off, make them transparent, like has some ways that they can interact with it when they're showing the family. I think is super beneficial. We're just like starting to figure out how do you do that in a way with like, navigating HIPAA things, but I think, there's plenty of opportunities for this. Yeah.
Probably show how naive and how old I am, but traditionally I was under the impression that for abdomens and heart, CT was a better image because of the movement, and you could get rapid images, and MRI, because it took longer to acquire the images, had more difficulty with movement. How do you do MRI with a moving organ?
Yeah, so a lot of our patients are sedated for their MRIs. The CT, so if you just wanted I just want a quick anatomic look at things, not a moving CT of the heart beating, but just a picture of a coarctation. They can just fly through the scanner in half a second, and they swaddle them, feed bundle them, and it's very quick. And it's higher resolution than the MRI, especially for those younger neonates. So that still tends to be our preference in like kids less than 6 months when we want a quick look at things. If you want all the physiology that comes with an MRI, we do tend to use sedation. There are some programs that for a more targeted study with MRI have tried things like that MRI compatible incubator. Some have even tried like a medvac type of immobilizer. So, I mean, it's like the things that we use in the ER for, for that, the age kids where they maybe can't quite sit still, but doing some feed swaddle type of techniques. But it's challenging because if they do move, you're averaging the picture over multiple heartbeats, for the 40 flow over 10 minutes. And so if they do move around, then it causes noise in the data set. So that's part of the challenge of how do you get some physiology from MRI, with the quicker, easier to get CT. But I think we have discussions in conference where we get the picture from CT, and then people ask, well, what's the physiology? Or how much is going to this lung? How much is going to that lung? How much is going to the body? And we tend to get a lot of that information with cath, but the MRI is a more non-invasive technique for us to get at some of that. So that's sort of the pros and cons in balancing, what each modality is good at and what, some limitations. So, yeah, good question.
I'm curious, how much manual curation goes into creating one of these models?
That is a good question. So I think it does take a decent amount of time. I mean, I think it takes our 3D team sometimes like a day to work through this, and so it does take a decent amount of time. And I think that's where some of the AI segmentation tools are really starting to become more helpful. The problem is you give the AI models that are built off of 100 normal adult hearts a really complex congenital heart model, and it just spits out nonsense. And so finding ways that we can still make it more patient specific and accurate, but use some newer segmentation tools, I think would be ideal, but it does take up a lot of time. Yeah. So as you're probably guessing from the pictures. Yeah.
Thank you for spending that time. One question from online. Has there been any patient experience studies or focus groups with older kids or adolescents to understand their own hearts and help with self-efficacy?
Yeah, no, it's a good question. I think for now, I'm starting with like using it for pre-surgical planning, and then kind of going into more patient trainee education. I think there's lots of like applications as we're making these models and refining them for the clinical surgical planning. There's lots of opportunities for doing that. So I think something like with sharing with the primary cardiologist, who can then share with the family, who can then show their adolescent teenager, I think is super helpful. People have definitely, studied that in the literature, and have found it, to be especially helpful for patients and families. So I think trying to find ways to continue to incorporate that, but that's a good question.
Agreed. Any other questions in the room?
Are you able to get more accurate pressure estimates from the flow, and have you compared that with like cath data?
Yeah. So one of the biggest limitations with a lot of our non-invasive imaging techniques is we can't easily get to pressures. You can use like the computational flow models to estimate pressure changes, but really that's why a lot of our kids end up needing a cath, is to measure pressures in each chamber. And then once you have the pressures and the flows, you can get to resistance through the lung bed, the pulmonary vascular resistance. So it's a challenge. That's one limitation of all these non-invasive techniques, is we can't quite get to pressure and resistance very easily. We get anatomy, function, and flows pretty well, but not that, so I think that is where cath tends to come in for a lot of our patients.
Well, this was very cool. I can't wait to see how this progresses over time, and we're so lucky to have you here, Dr. Brown. So thanks, everyone, for coming. Thank you, Dr. Brown, for all your work, and we'll see you all next week. Thank you.
Thanks so much.